Kars works in Germany, and he is, I think, one of the most experienced PFA physicians in the world. Thank you.
Well, thank you, Steve, for the invitation. It's a great honor to be here amongst all the great names in electrophysiology. So, this is my title, and thank you for the title, by the way, Steve, because it really caused me some headache. Ventricular PFA, theoretical challenges and potential promise. And I really had to read the title 3 times to really understand it. And once I understood it, I was like totally depressed because I really had to make every slide for this presentation. So it cost me a lot of work. So these are my disclosures, ladies and gentlemen. And ventricular ablation presents a distinct challenge not encountered in atrial applications. The wall thickness exceeds, of course, more than 12 millimeters, and there are complex there's no slides, sorry for that. The wall thickness exceeds more than 12 millimeters. And there are complex intramural circuits present, and there is, especially in the case of infarction, heterogeneous scar architecture. The physics that govern successful atrial PFA cannot simply be extrapolated to ventricular tissue without addressing these fundamental differences. And the central theoretical question becomes whether we can precisely control PFA lesion depth and selectivity in these disordered substrates. The theoretical foundation of PFA rests in achieving irreversible expiration thresholds, typically 700 to 800 volts per centimeter in healthy myocardium. However, these thresholds vary substantially between cell types and are significantly altered in scar tissue with fibroblasts requiring up to 30% higher field strengths than myocytes. And this creates fundamental predictability challenges in ventricular tachycardia substrates where cell composition varies dramatically across a small spatial region. So there is a very heterogeneous field. Electrical fields do not propagate uniformly in heterogeneous tissue. They distort predictably near boundaries between tissues of different conductivities. And computational models demonstrate significant field amplification at scar border zones, potentially creating unintended hotspots of ablation effects. Perhaps most critically, myocardial fiber orientation creates directional anisotropy that can reduce field penetration up to 60% when perpendicular to fiber orientation. And also, catheter orientation effects are very important on field geometry. The most immediate challenge in ventricular PFA is achieving reliable transmulality across walls commonly exceeding 12 millimeter, particularly in hypertrophic disease states. And computational models suggest that field strength decreases by approximately 80% at 10 millimeter depth using current waveforms, potentially falling below the effective thresholds. And this creates a fundamental barrier to assessing deep intramural circuits that drive many ventricular arrhythmias. PFA's theoretical advantage lies in its selectivity for myocytes while sparing nerves, vessels, and collateral structures. However, models reveal a fundamental paradox. Achieving deeper lesions requires higher field strengths, which begin to compromise this selectivity advantage. That means that creating a therapeutic window that must be navigated when targeting deep substrates near critical structures like coronary arteries or the phrenic nerve. And beyond hardware configurations, waveform engineering shows particular promise for overcoming ventricular challenges. And ex vivo studies demonstrate that high-frequency biphasic waveforms with variable amplitude can enhance penetration while maintaining selectivity. Another reason why waveforms are very important is because some monophasic waveforms can actually cause pro-arrhythmic effects like ventricular fibrillation, whereas biphasic waveforms are less prone to do so. And cardiac cycle resynchronization, cardiac cycle synchronization, I must say, becomes more critical in ventricular applications than in atrial applications, with data showing that up to 15% variation in effective field strength depending on local tissue impedance during different cardiac phases. And also the phase of the application matters when you look at the systole and the diastole of the ventricular wall. Because in the diastole of the ventricle, the wall depth is totally different than in systole. So also the timing of the application matters. Addressing ventricular challenges requires moving beyond simple bipolar configurations to true multi-electrode field shaping. And by precisely controlling phase relationships between multiple catheter electrodes, deeper and more uniform field distributions can be created. And here, for example, you see some examples how we can alter that. Because bench data demonstrates that up to 60% improvement in transmediality can be achieved using optimized vector field configurations versus conventional approaches. Limitations are that, for example, we have a problem in assessing the lesion formation. And a critical theoretical gap in ventricular PFA is the absence of a validated real-time marker for effective lesion creation. A novel EP recording system is available that uses a low noise floor and a 2 kHz sampling rate that can actually measure residual energy, possibly indicative for remaining local activity. And unlike RF ablation, impedance drops and electrogram changes correlate poorly with PFA lesion transmediality in ventricular preparations. And what we don't want to use, of course, is real-time MRI ablation, because that is really not very practical. Patient-specific modeling using pre-procedural imaging shows promise in predicting field distribution, potentially enabling true substrate-specific energy titration. Perhaps the most pragmatic near-term approach involves leveraging both thermal and non-thermal energy modalities in strategic combination. And recent preclinical models demonstrate that RF pre-ablation increases tissue conductivity and enhances subsequent PFA field distribution. And this hybrid approach shows particular promise in infarct border zones where 40% improvements in lesion transmediality can be observed versus either modality alone. Despite promising advantages, fundamental questions remain. What are reliable electroporation thresholds in heterogeneous ventricular scar? And can field geometry adapt dynamically to substrate variations? And is hybrid RF and PF therapy viable for complex circuits? And what procedural markers reliably indicate durable lesion creation? Answering these questions requires collaboration between engineers, electrophysiologists, and computational modelers. In conclusion, ladies and gentlemen, ventricular PFA faces substantial theoretical challenges related to transmurality, tissue heterogeneity, and predictable lesion creation. However, emerging solutions in field shaping, waveform customization, and lesion assessment show promising paths forward. As one colleague aptly noted, PFA is not just an energy source, it is an engineering problem, and it's a problem that demands our combined expertise to solve. I'll conclude with this thought that captures the central question. Can we truly achieve precise electroporation effects in the inherently chaotic substrate of ventricular disease? I believe the answer is yes, but only through rigorous application of biophysical principles and continued technological innovation. Thank you very much.